I do think that this subgroup with ejection fraction below 50% and more than 40% might be the one where beta blocker will have a role to play. And I'm really hopeful that the next set of guidelines will make some recommendation in the favor of this group, taking into consideration all the evidence now.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Our guest on today's show does not need any introduction. She has been on Parallax before. She is our regular feature when it comes to summarizing ESC for us, the European Study of Cardiology Congress, and she does a stellar job. So, when it's this time of the year, I usually send my annual text to Purvi requesting her to do this for us. So, Dr. Purvi Parwani, she is Associate Professor of Medicine at Loma Linda University Health. She is the Director of the Echocardiography Laboratory at Loma Linda. She's someone who I don't think needs any introduction in the cardiology world. And with that introduction, Purvi, welcome to Parallax.
Thank you, Ankur. Again, I'm always delighted to do this episode because I feel like it's a way to connect with your listenership and the audience. And of course, we talk often, but this is when we talk deeply about cardiology. And I've always enjoyed our conversation on that. So thank you so much again for inviting me.
Of course, no, it's our pleasure. You do such an amazing job in summarizing these. And first off, I think ESC gives us such I want to say it's like a double bolus of trials and knowledge that it just gets hard to absorb everything. And so, what I've found in doing these with you is you are succinct and you summarize, and there's a theme to how you pick these for our listenership. So, with that. We have quite the agenda for today. So we're going to start with, I think the way I've organized your list, Purvi, is to sort of talk about the beta blocker trials first, then go into heart failure, and then finally summarize with the aspirin trials. So we're going to start off with the beta blocker trials. Why don't you tell us more about REBOOT?
Yeah, I mean, I think that both REBOOT and BETAMI-DANBLOCK were totally probably the highlights of this ESC, right? As I was telling you before we started recording, that, in cardiology, we have realized we have all this really good technical advances. We have excellent GDMT, but slowly we are questioning ourselves, right? And this is probably the only subspecialty where we establish evidence and then we try to again, test that evidence. And I think both REBOOT and BETA-MI, kind of in the similar population, were trying to solve this very simple question. And this is why I like all these trials that we have picked. Some of them are truly answering a very simple question and just challenging that status quo of giving beta blocker to all post-MI patients within 24 hours of myocardial infarction. So I think, Ankur, as you know, the ACC-AHA guidelines for the management of ACS recommend starting beta blocker within 24 hours. And that is, the evidence there is class 1 recommendation, level of evidence A. And that is to reduce the risk of ventricular arrhythmias and reinfarction. European guidelines as well, similarly, recommend the routine use of beta blocker for all ACS patients, regardless of their LV ejection fraction, but there they weaken the evidence to class 2A. And this has been challenged before. This evidence has been challenged before last year with a trial called REDUCE-MI, you might remember. Again, REDUCE-MI kind of also found that the long-term beta blocker therapy with acute MI and preserved ejection fraction did not reduce the risk of death and recurrent MI. And I think why all these investigators are so keen to test it is because, of course, the last, these class 1 recommendation that has been given to the guidelines, that comes from the trials that were, done before we had these all really good stents, right? We didn't have routine reperfusion. We didn't have complete revascularization. We didn't didn't have the fancy drug-eluting stents that are so excellent. And then more importantly, we didn't have this excellent contemporary GDMT therapy that we have now. So, all done before we got into cardiology. And now with all these technical advances, of course, we are going to challenge, use of beta blocker, particularly in the patients with LVEF more than 40%. So let's speak about REBOOT. I think REBOOT was done between Italy and Spain. I think it enrolled around 8,500 patients, open label trial. My only complaint with this trial is only 19% women, but I'll tell you something important even with that regard. LVEF, as I said, more than 40% randomized to beta blocker and no beta blocker, on an average around 4 years of follow-up, and no significant difference in risk of death of any cause, reinfarction or rehospitalization for heart failure in the patients treated with beta blocker versus they weren't, those weren't, right? And also, even in the secondary outcome, no different whatsoever. Now, what was worthy noting is that when you selected patients less than 50%, so remember, inclusion was more than 40%, and so this is between 40 and 50% EF, there was a trend towards lower risk with beta blocker. But guess what? With 19% women didn't do well. So women did not do well with beta blocker. We know that the latest ESC guidelines have actually downgraded use of beta blockers post-MI in women. And I think we are just going to build on that evidence going forward, how women do with beta blockers and why there are differences, etc. But I think in nutshell, that is what REBOOT was about. And then once we discuss beta MI, then I think we should also discuss the meta-analysis that was done with the two of them and one more Japanese trial. But what do you think about REBOOT?
Yeah, so excellent summary, Purvi. So I'm going to tell you what I started doing. Like you mentioned, with the advent of modern or second generation drug-eluting stents, which are in clinical practice, the second generation stents are what we use now. And, we revascularize patients fairly quickly. I mean, door to balloon time, that the standard is 90 minutes. Most hospitals, achieve, even total ischemic time, I want to say, is not even 90 minutes these days. And fortuitously for our patients, most of them, get discharged with normal ejection fraction on a transthoracic echocardiogram. So after Reduce AMI was published, I actually changed my practice. I would not send them out on a beta blocker now. And you mentioned the reasons. I think beta block, particularly in the young. So if you're in the 50s, 60s, if you're active, beta blockers cause severe fatigue. A lot of these patients feel like I feel worse after having gone through this. And some of it is psychological, obviously, but a lot of it is beta blockers. And if you don't have to, if someone's not hypertensive, which you'll find these patients. I mean, you'll find patients who are normotensive, just had this random plaque rupture, single vessel coronary disease. You stented it, they're fine. EF is normal. They're not hypertensive. There's no need for a beta blocker, in my opinion. And I think. So Reduce showed that, right, which was presented, I believe, at AHA, and then now we've got two of we've got REBOOT. I think you're going to talk about BETAMI-DANBLOCK. So and then you mentioned about the meta-analysis, which I'm glad you mentioned. Lancet published it. Professor Fuster was is one of the co-authors there. So in case the listenership is interested and want to read that paper, we'll include it in our show notes. But I think, like you mentioned, the advent of beta blocker therapy in the setting of an acute coronary syndrome or an acute myocardial infarction was probably in the pre-PCI era, or in the pre-contemporary PCI era, I should say. And now that we achieve immediate revascularization, their role is getting questioned.
Yeah, and think about just not immediate revascularization, good revascularization. You guys have imaging, you have OCT, you have IVUS, even for complex lesion, etc. Right, complete revascularization post MI. So all of these things, I think, are and of course, then GDMT, right? For even for I would say primary prevention, lipid lowering, etc. So I think all of that is kind of adding, and I absolutely agree with you. I don't see CCU patients, but I do see these patients in follow up in clinic regularly, and that has been absolutely my approach. That when the EF is normal and they're otherwise doing well, and they don't have a reason to be on beta blocker either because of angina or high blood pressure or arrhythmia, I tend to shy away. But I think let's just discuss beta MI. And you are absolutely right. The reboot actually, Dr. Fuster was. I think he was one of the investigators, and it was done in Spain, Italy. Beta MI on the other side, or BETAMI, however you want to pronounce it, that combined BETAMI-DANBLOCK combined two studies. One is from Norway and another one is for Denmark. And absolutely identical design, except think about the patient population. These are the northern, European countries. And what we know about Denmark and Norway is they have really good registries. So they're very good with picking up any events whatsoever. So even though there was identical design and similar inclusion-exclusion criteria as far as the ejection fraction goes, I think one important distinction was that I think DANBLOCK did not require the complete, revascular or coronary revascularization. So that might be another difference between the two trial. And the third thing is that I think the proportion of patients between 40 to 50 was higher in beta MI DANBLOCK compared to the reboot. So that might be the third difference why we had completely different results with beta MI DANBLOCK. So this trial was less patients, I think around 5,500 patients. Again, only 20% women, similar to the previous one. That is my complaint with these two trials. Again, the EF cutoff was more than 40%. And I told you already about the revascularization, similar follow-up, 3.5 years, similar endpoint, death from any cause, MI. They also included unplanned revascularization, ischemic stroke, heart failure, or ventricular arrhythmia. And here there was benefit. Now, benefit was driven, benefit with beta blocker that was driven by lower risk of myocardial infarction. Again, the subgroup analysis, the benefit favored that mildly reduced EF 40 to 49%. And I told you proportion of that 40 to 49% was higher in this trial compared to the previous trial, which might be, responsible for the benefit with beta blocker in this trial compared to the previous one. Now, I told you I'm going to tell you about the meta-analysis. So all these investigators also participated in the meta-analysis, and that was also discussed at the ESC. So that included REBOOT, BETAMI, DANBLOCK, and capital RCT, which was a Japanese trial that tried to test carvedilol in STEMI patients with PCI, and they included I think LVEF 40 to 49%. And again, as we have said before, the benefit was in that group, 40 to 49%. Composite endpoint was reduced by 25% with beta blocker therapy. So I do think that this subgroup with ejection fraction below 50% and more than 40% might be the one where beta blocker will have a role to play. And I'm really hopeful that the next set of guidelines will make some recommendation in the favor of this group, taking into consideration all the evidence now there is that. Now, Ankur, just to think about this, if we look at, as you said, a lot of these patients, when we take care of them with ACS, they are walking out with normal EF. And believe it or not, that percentage is almost 40% of our ACS patients have ejection fraction 50% or more. So just for your listenership, I think it's an important point that, we kind of are, we are aware of this evidence and we don't overtreat our patients, particularly given the side effects that you mentioned with beta blocker in younger group.
Yes. Again, excellent summary for BETAMI-DANBLOCK and the meta-analysis, the risk reduction, just for the listenership, it was relative risk reduction 25%, as you mentioned. And if it's 49, so if it's between 40 and 50%, prescribe them with a beta blocker. You can pick the beta blocker of your choice. I tend to go with, carvedilol. I know in the UK that they prefer bisoprolol. A lot of these centers also like metoprolol succinate. Really depends on what the baseline blood pressure is. Right. I tend to view carvedilol as a medication which has a more potent blood pressure reduction effect because of its alpha blockade also property. And so if you're looking to just blunt the heart rate and somewhat preserve the blood pressure, go with succinate. Otherwise, prescribe bisoprolol or carvedilol. But like you mentioned, more than 40% of our acute MI patients, with either non-ST elevation MI or STEMIs or have preserved ejection fraction. And in those patients, you can make a case of not prescribing one, which I think is sort of in the cardiology world is tectonic shift, because not until recently beta blocker therapy post-acute MI for 3 years was a class 1. As you mentioned, it still is a class 1. So, I think maybe the guidelines be like it's a class 2A in patients with preserved EF, and then it remains a class 1 in patients, because we have 2 trials now, or 3. So class 1A in patients with EF between 40 and 50%. Anything else you think we should discuss about these trials?
No, I think I think these are the trials from ESC truly will make a huge difference from this year that were, that were released at ESC and published simultaneously in NEJM. So really, practice changing trials. And this is why I'm glad that you're going to summarize all these papers in the, you're going to put a link for the viewership. But these are the trials that are going to be practice changing. So really a request to the audience to take a look at this and apply to your practice, as such. As if we look at how much time it takes from the evidence to the practice change is on an average 17 years. And this is why what you do, right? With Parallax, etc. We are trying to disseminate, the knowledge, and I think it's so important when the evidence is so good and strong and work has been done. We pay attention to it. So that's all I would have to say about beta blockers.
Yeah, no, absolutely. What you do, not only by being here on Parallax, but also on X and other platforms, is you are a voice for health literacy and dissemination of important work, which our colleagues investigators do, and that's hard work. It takes a lot of effort, takes a lot of money to get these trials done, and so it's important for people like us to help our colleagues who are investigators to then disseminate this to our colleagues who are taking care of patients in the trenches. So yes, we will include the show notes for both REBOOT, BETAMI-DANBLOCK, as well as the meta-analysis, the Lancet meta-analysis. So moving forward, thank you for bringing this trial to my attention. There was, like I said, ESC always comes up with such a bolus of information that I missed on this one, and only read up on it once you sent me the list that you were going to discuss. So before I go to DigitHF, which I did read, let's talk about POTCAST on this podcast. So tell us more, and which, I think just to even come up with the idea of doing something like what they did in podcast, and you'll tell us more about this, was fascinating to me, because I was trying to sort of untie where they got the initial evidence from, even to do the trial.
Yeah, I mean, again, the fascinating thing is so simple, right? Like such a simple question, and I would say relatively a simple solution to the problem of arrhythmia, low level of electrolytes, and relationship between arrhythmias, heart failure, and death. Something that we encounter as cardiologists. In fact, I would say that I'm sure you remember those internship days where the nurses will wake you up on an overnight call because someone's potassium is low and they are having non-sustained VT, right? Like we all have experienced it. And I'm sure you have memories of the internship days, getting called, right?
Yeah, memories of those call rooms and being in the hospital and getting paged on potassiums of 3.2 and 3.4. And
Exactly.
patients having either PSCs or runs of non-sustained VT, and next thing you do is you check a mag, and then you supplement both K and mag, and then you do another blood draw.
Yep. So I think it's deep rooted in medicine, right? Like the electrolytes and the arrhythmias and the relationship between the two. So I think, believe it or not, the data is mostly from the observational studies that have shown a link between low level of electrolytes and I think also, of course, observations of all of us in the field. But basically, if you have lower level, that really equates to poorer outcome compared to the higher level. So, podcast was designed with an idea that if you uptitrate the potassium level, then you can improve the outcomes in this vulnerable population. And who is the vulnerable population? Well, they investigated. I think it's 1,200 patients with who were at higher risk of ventricular arrhythmia. So either they had an ICD or CRT, and they had baseline potassium level of less than 4.3. Almost 60% of the patient had history of heart failure. Half of them had history of CAD. Other half had primary cardiomyopathy or primary arrhythmic disorders. And the uptitration, they randomized to potassium uptitration versus standard care. And the uptitration was achieved either by using the potassium supplementation or MRA along with dietary guidance. And whenever possible, use of MRA, but decreased use of thiazides or loop diuretics like Lasix. So more aldactone and less Lasix and thiazide, dietary advice, and potassium supplementation. Something that we all do. In fact, yesterday or on Friday, I saw a patient who has 20 days history of she was in trigeminine clinic, but palpitation and potassium level was very low, right? So something that we all do on a regular basis to increase potassium. So such a simple idea, simple solutions, just changing the medicines on a patient. So the baseline level in both the groups was 4, and it was increased to 4.4 in the interventional group, and I think it stayed at 4 in the control group. And the endpoint had sustained ventricular tachycardia more than 125 beats per minute, lasting for 30 seconds, shock by ICD, or ATP by ICD, unplanned hospitalization for arrhythmia or heart failure that lasted for more than a day, or required medicine or invasive treatment, or all-cause death, because of all of this. So, and then they followed these patients for almost 40 months, and there was benefit. So I think overall potassium supplementation had a lower risk of composite endpoint. I think it was 22 by 29% with a hazard ratio of 0.76. And the effects were consistent in all the subgroups that I mentioned, like so heart failure, the CAD subgroup, the patient who had or had not taken an MRA, who had or had not, achieved the target potassium target, but had increased potassium level. And the difference were driven by reduction in ICD therapy or VT, incidence and unplanned hospitalization for cardiac arrhythmias. Now, heart failure hospitalization did not change. All-cause death did not change. In terms of safety, because you're giving potassium, so is there a concern for kidney failure, hyperkalemia, etc.? There was no difference between the two group, and so I think that if we look at overall this trial, heart failure patients we know tend to be on the loop diuretics. They tend to have hypokalemia. They also are the ones who would require ICD, are at higher risk of, VT. So these are the patients to target. These are the patients to achieve that, optimal potassium level. And I would say that we do this, but I think that time to take this simple solution into consideration and perhaps do it more aggressively, in our heart failure patients. I think a lot of hospitals in United States have APPs taking care of these patients, electrolytes, as well as diuretic therapy. And I think, in our hospital, we use this template for GDMT. I think potassium should be one of the points in that template, where you are maintaining potassium level for these patients, and is it optimal or not, so that we can reduce the arrhythmic events as well as the ICD shock for this very vulnerable population.
Yeah, I mean, like you mentioned, the solution is simple. Now they did a combination of both potassium supplementation and or mineralocorticoid receptor antagonist, because the targets they were targeting was like between 4.5 to 5, so fairly high, right?
Yes. Yes. But then remember that the mean level that they achieved, in the interventional group after the adjustment of, I think I want to say they tried for almost 3 months, that was 4.4. So remember, Ankur, these patients are not easy to get, even when in a clinical trial, um, even with all of these changes, they got to 4.4 because a lot of these patients tend to be on loop diuretics. All the SGLT2 inhibitors have diuretic effect. So they are losing electrolytes in general, the heart failure population particularly. And I think 60% of the patients were heart failure, primary heart failure, 64%, I would say. So I think even in spite of all of these changes, even though their target was 4.5 to 5, the average increase in that intervention group was 4.4. So something to keep in mind.
Yeah, well, thanks again for introducing this one to me. Again, simple study, neat study, very relevant to the patient population that we deal with. Like you mentioned, a lot of these patients are cared for in heart failure clinics, which are run by advanced practice providers, and I think it's a good target to achieve. It's a good checkbox to check off. Once you are seeing these patients, either following a recent hospitalization or as part of your follow-up panel. Which then brings me to, now that we're talking about heart failure and advanced practice provider and heart failure clinic, let's talk about DigitHF, which again is sort of the pendulum has swung from one way to the other, and then it's swinging back. So what did DigitHF tell us?
Yeah, another fascinating, simple study, I would say. Digitalis or digoxin has been in our life since the internship days, or I would say, a lot of us know about this, particularly the foreign medical graduates, because, back home in India, before we came here, I think the heart failure treatment, a lot of these patients and, all those severe MS patients that we took care of, rheumatic MS patients that were advanced heart failure due to valvular disease, they were all on digoxin, right? So we got introduced to digoxin fairly early in med school, you and I. And we have known this drug for a long time. The problem with digoxin, though, is, as you know, it's excreted by kidneys. And when the kidneys are bad, you suffer with the digoxin level, and then there is digoxin toxicity, etc. On the other hand, what this trial, DigitHF, tested was digitoxin, which is a bit different than digoxin. It's pharmacodynamically like digoxin, but then it gets excreted by liver, not the kidneys. So I think it's a bit safer because the serum concentration does not require that much of dose adjustment. And the evidence for digoxin comes from the DIG trial. DIG trial was done in 1997. And back then as well, what it showed was if you take heart failure patients, digoxin will reduce the risk of hospitalization for worsening heart failure, but it does not reduce the risk of all-cause mortality, predominantly because of all the side effects that come with digoxin. So there we were, and let's come back to guidelines. So till date, the last heart failure guidelines for the United States, there is a 2B indication to be using digoxin for the patients with heart failure reduced EF who remain symptomatic and cannot tolerate to GDMT, or in addition to GDMT, when GDMT is not enough because they are so symptomatic. So even in last guidelines, the doc does receive a 2B recommendation. Now, DIGIT-HF gets published in 2025 in NEJM, and it was a long study, 10 years, and unfortunately, they lost funding. They were supposed to enroll, I want to say, around 2,500 patients, but unfortunately, because of the funding loss, they enrolled only around 1,200 patients. Only 20% of the women, that's a theme. Chronic heart failure, LV ejection fraction less than 40%. But what was remarkable with this trial, which you have to congratulate the investigators for, is they enrolled sicker patients. And so they had more NYHA class 3 patients than class 2 and class 1, right? So most of the GDMT trials, if we look at for the SGLT2 inhibitors or ARNIs, compared to all those trials, these investigators did enroll sicker patients because they realized that that's where probably the drug might be suitable for. We have really good GDMT, so you are only gonna make a difference by showing an impact of this drug in the patients that are much sicker. They are either not able to tolerate or they remain symptomatic in spite of good GDMT. And they had excellent GDMT compliance, 90% patients on beta blocker, 90% around on the ACEs, 40% were on ARNI out of that 90% ACE group, almost 75% on MRA. SGLT2 inhibitors were less, I think around 20%, but then these patients were sick. A lot of them, 2/3 of them were treated with ICD already. Almost 1/3 had CRT therapy. So a really good group where you would, it wasn't, they did take care of these patients already on the existing heart failure therapy. And their primary outcome was composite of all-cause mortality and hospital admission for worsening heart failure. And it did show a difference. Almost 40% patients with digitoxin had primary outcome compared to the 44% that were randomized to placebo. And the difference was statistically significant. There was a favorable impact of the digitoxin on individual primary outcome, but it wasn't significant statistically, predominantly probably because their target was 2,500 patient and they only did half. Now, you might ask about the side effect because that's one of the things that we worry about this group of medicine. It was not bad. Around 4.7% of the patients in digitoxin had side effects and around 2.8, so 5 versus 3%, so not bad at all. There was not subgroup analysis. If we look at the patients that had ICD had a larger impact, with the risk of all-cause mortality. And the thing is, in spite of doing 20% enrollment with women, with digoxin, we know there were sex-based differences in outcome. Again, women, had higher risk of death from digoxin. With digitoxin, that was not true. So it had similar impact on both men and women. So I think that's important, point to take a note. Now, overall, it was they couldn't enroll that many patients. Of course, the effect size is smaller, and that's what it got kind of criticized for in the post trial discussion, that where does this drug belong in our heart failure world. We have really good GDMT, and the effect size is small. So I think that's the thing. We'll have to find a place for DigitHF to fit. But I do think that there are a lot of patients, in my opinion, that are sicker, that cannot tolerate the current GDMT. And there might be a role for this, this medicine when the 4 pillars are not enough.
Yeah, Purvi, again, excellent summary. So, like you mentioned, I mean, these are sick patients, right? Like EF is less than 40%, NYHA class 2, 3, if 3 or 4. So if your EF less than 40%, NYHA class 3 or 4, if your EF is less than 30%, those were NYHA class 2. So sick patients, good background guideline-directed medical therapy, maximally. A lot of these patients, I struggle to put them on all 4, quite frankly, between their blood pressures that actually get really soft on a BID dose of sacubitril/valsartan. You add a whiff of an MRA, and then SGLT2I. Most of my patients find it to be very financially toxic, and you have them on beta blockers. So most of them respond. They respond very nicely to this quadruple backbone medical therapy. I continue to struggle with cost. When it comes to some of the patients, but in part could be because of the pair mix. And then to have a drug which is like it's dirt cheap. Its Box Club has been, like you mentioned, and has been in medicine forever. For that drug to come back after all these years and show a mortality benefit is huge. What is in terms of because it was not only cardiovascular mortality. I mean, this is all-cause death and hospitalization for worsening heart failure. So do you see yourself prescribing this again, Purvi? Because, this was, I'm very honestly, like this digoxin was out of my armamentarium. I was not prescribing it. As a matter of fact, I was discontinuing it in patients who were still on it.
Yeah. No, I think there's definitely role of it. As I said, I practice in San Bernardino County. You mentioned the financial constraints, and unfortunately, that's a big part of what we see in the patient population that we deal with here. Compliance is a big issue, right? Particularly when the patients are not able to tolerate the medicine. I agree with you. SGLT2 inhibitors, I like those drugs. They are mind blowing, but unfortunately, so many patients just with this whole UTI thing or, with a higher copay are not able to tolerate them. So I think if you have a good team, in your heart failure clinic where you have a good team of APPs that are supporting you, they are able to check, patients' electrolytes, etc. You have a good handle over your patient follow-up. Then I absolutely think there is a role for the patients that are not able to tolerate. Remember that DigitHF also, these patients, it was actually these patients had higher rate of utilization of ivabradine. And why that is because, of course, they are not able to tolerate the beta blocker. Their blood pressure is soft, and they use ivabradine. And ivabradine is another expensive medicine that even in that group, I have so much hard time, with insurance, and I struggle quite a bit to get it approved. So I think all of those things, patients with ICD had a better benefit, all-cause mortality you mentioned, and that is because of the impact on, of heart failure and arrhythmias on, different system if you have to extrapolate it. So I do think that there is a role when the other things are kind of when the other things kind of fall short, on side, whether because of the financial constraints, because of the side effects, because of the low blood pressure, whatever might be. But 4 pillars of heart failure therapy are here to stay. So I would absolutely try my best to get those patients on all of those medicines first. And if I fail, I'm glad that I have this alternative. I'm glad that there is a positive study, even if the effect size is smaller, because I know that probably that effect size would have been larger if this study enrolled, and that's just a speculation, but I would assume that it would have been larger if they enrolled all the patients. They only enrolled 55% of their target. So hopefully, this also gives food of thought for, future investigators. But I think overall, I'm happy with this trial, and that's why I decided to include, because it's cheap. It's, I think, in today's environment with where the healthcare is going, I think it is applicable to discuss, and this might again change the guidelines. We'll see. Right now we are at class 2B. Does this earn digoxin class 2A? We'll see, but that's the question to be answered.
Yeah, and just for the listenership, I know you mentioned this at the beginning of the discussion of this particular trial. We are talking about digitoxin. We're not talking about digoxin. There's an ongoing trial, similar trial, which is ongoing with digoxin in chronic heart failure. It's called Decision. The results are not out yet. So this is digitoxin. So, and in case, some of you or some of us, I was actually wondering, should it be, nowadays you have pharmacy and with the, you mentioned several times, you mentioned, advanced practice provider run clinic, and I'm going to give a shout out to our APPs, Tasha, Emily, Leah, Sarah, Kristen, Abby. We're in the process of forming one, at our organization. And so, for APPs who are listening, if you want to extrapolate the results of this particular trial into, to your existing patient population, which I think you can, reasonably you can, then maybe check with pharmacy with the dosing, the dose that you want, stable dose that you want to use. Maybe if it's 250 mics a day, once they're adequately loaded.
Yeah. So Ankur, with that, actually, I don't think that the digitoxin in United States is FDA approved. So, we'll see how it changes the entire paradigm of this drug. But right now, we just have digoxin. And that's why I was saying, does this give, another food for thought? And that trial with digoxin, as you said, is pending. So we'll see. I think the important thing is trying the future trials, where exactly, what is the patient population they select would be key, right? Because we do have 4 pillars of heart failure therapy. So we'll see how the, paradigm changes. But you're right, the pendulum has swung back into the direction where it started.
Yeah, so moving forward, I think we're coming into this last section of the podcast the way I had divided it into different sections. We started off with we started off with talking about beta blockers, then went on to heart failure, and now let's talk about aspirin. So I think we're sort of we're shaking the foundations of cardiology in this episode. So aspirin has been ubiquitous with cardiologists and is sort of the first drug you think about when you think about cardiology or heart. And the very existence of aspirin and its prescription is coming into question. So let's start off with the PCI trials first, Purvi, and then we can talk about AQUATIC. We'll let you start with the 2 PCI trials that you've selected for us.
Yeah, so we're gonna select. I selected Neo, Mindset, and Target first, and both very relevant, right? As you correctly said, if you look at the theme of all these trials, we are just kind of trying to reduce the amount of depth and amount of medicine that we are trying to give our patients. So, and that is, on background of all of that is really good revascularization, contemporary stenting. bleeding, complete revascularization, really good imaging post-revascularization. So I think that all of that plays a role why investigators are trying to figure out what is the optimal duration that our patients can benefit without any risk. So really, really good, well-designed trial. I would say gutsy with Neo Mindset. So let me tell you about this. So we know DAPT post ACS 12 months is recommended, but we know that there have been several trials with de-escalation therapy. Why? Because bleeding risk remains high in patients with DAPT, and then there is ischemic risk, which is absolutely high in the first month, actually 1 to 3 months. But what is that optimal duration? And that was the kind of the background of these two trials, I would say. So NeoSoft was, again, it's published in NEJM. And this was conducted in Brazil. They did it in around 3,400 patients. And they actually withdrew aspirin in the first 4 days of hospitalization after successful PCI. So that was one group. And then that group got either ticagrelor or prasugrel, or the second group was standard dual antiplatelet therapy with aspirin and second P2Y12 inhibitor for 12 months. And the primary endpoint was death from any cause, a myocardial infarction, stroke, urgent revascularization. That happened in 119 patients in the monotherapy group, which was just either prasugrel or ticagrelor, and 93 patients in the DAPT group. It failed to demonstrate the non-inferiority of the aspirin-free monotherapy that was initiated right after the PCI over 12 months. And why that is because we realized that ischemic risk of these patients in the first month post-PCI probably is extremely high. So I really found it gutsy for this investigator to withdraw aspirin in 4 days. And I was really hats off to them for even trying, because we know from the previous data that, there are so many Asian trials and United States trials that have, tried this question of what is good. Is it 3 months? Is it 1 month? But they went beyond in that 1 month, what might be the duration. So I think really hats off to them. Unfortunately, didn't meet the, cutoff, which sets the, which sets the foundation of the very belief that we all have that aspirin probably is essential, for these patients. So stent thrombosis occurred almost in 12 patients in the monotherapy and 4 patients in the DAPT group. Of course, as we all know, the non-major bleeding was higher in the DAPT group, 82 patients in the DAPT group and 33 patients in the monotherapy, but that was non-major bleeding. So I think that in nutshell is what Neo Mindset. And then the second one that I had selected kind of on the same thing was Target First, again published in NEJM. And it again showed that P2Y12 inhibitor monotherapy was non-inferior to DAPT, but here the duration was different. And let me tell you about this trial. So again, kind of the same question, what exactly is that duration? So of the DAPT versus aspirin-free, monotherapy. So they enrolled around 2,000 patients. So either aspirin-free monotherapy with any P2Y12 or DAPT for 11 months. And I think here they achieved the non-inferiority. Of course, major bleeding happened, more in the DAPT group. I think around 6% patients had the DAPT group had bleeding, 2.6 in the single arm therapy. But the incidence of stent thrombosis and other adverse reaction related to the ischemic risk was similar between the two groups. So I think 4 days versus 1 month? And answer is clear that perhaps in the patients with higher bleeding risk, 1 month of aspirin still remains essential, if not 3 months. And the question really is, what is it applicable to all the patients? Ankur, you are an interventional cardiologist. I don't deal with these patients that much. Is it applicable to all the patients, or do we limit this evidence to the patients that come with high bleeding risk and or they have to undergo a surgery, essential surgery like a cancer or something? So that's the question, where again we stop. Are we gonna discontinue aspirin early on, looking at this evidence, or are we going to just be the cardiologist that we all are? I tell you, I get always, a little, I don't feel good when I discontinue aspirin early on. But, evidence is there. And what are we going to do with this? And how clinicians are going to change their mindset is the question we got to answer. Because I tell you, I get nervous even after all this evidence that is mounted. So I want to hear your thoughts on that.
Yes. Again, thanks for the summaries. Excellent summaries. So I'm going to share what I do, and that obviously pivots as new evidence accumulates or is garnered, and you also there is garnering clinical experience with each passing year. So I agree with you. I mean, I think if I'm stenting someone with an ACS, at a minimum, I want to see them on DAP for 6 months. You can push it for 3 months in some who are wanting to have a procedure. And here's the other thing which I've seen, and this is sort of a phenomenon which is I've seen over the last maybe 2 or 3 years as a practicing interventionalist, is that patients, for whatever reason, feel that once you've stented them and once the procedure is done, they can essentially stop the medication whenever, because they are like signing themselves up for elective dental procedures, elective orthopedic surgeries, and I'm usually on the phone with them, and it's like, no, you cannot do that. You just had like an event 3 weeks ago, 4 weeks ago. You have to cancel this procedure. You have to cancel your dental appointment. And now I have become more lenient when they are maybe 6 months out of an acute MI. And then too, I say, be careful. You can stop it, you can get your dental procedure done, and then go right back on it as soon as possible. Definitely a P2Y12, if not aspirin, because we know now. I mean, this is going off on a tangent here. This is not the topic we're discussing, but in chronic coronary syndrome, as you know, there's accruing evidence of P2Y12 monotherapy, which is preferred over aspirin alone. So, my practice has shifted toward that. In chronic coronary syndrome, I'm very comfortable with P2Y12 monotherapy, and I've started supplanting, and a lot of these patients have started supplanting aspirin to clopidogrel for the most part. So in any event, coming back to your question, so I would never be able to stop aspirin 4 days out.
I mean, I think that, we saw in Neosoft that they were not able to achieve non-inferiority. But, I think that to me, like, okay, 1 month, I'm sold. 1 month, you absolutely need to marinate that stent in, dual antiplatelet background. But I agree with you that, just the, our gut feeling or the intuition is like, we don't want our patients to be the anecdotes, right? But, to be honest with you, on the other side, if you put our scientist head, there's so much mounting evidence that actually it's not that bad. So I think it's going to come down to like personalization, right? Is it a complex lesion or non-complex lesion versus like a multi-vessel, PCI and setting of shock, versus like a simple, straightforward, single disease, which I think target first was all like mostly, I think I want to say 70% was just single disease, single vessel lesions, right? So did you use the imaging, did you use IVUS to figure out if that stent was well opposed and you're going to have less risk? So I think all of those things are going to come into play. Hopefully, I think right now what we use DAPT score, right, to figure figure out, or you use, or you look at overall bleeding risk. But I think I think that going forward, we are going to have these, EPIC system is going to be so smart. The way you get your QI indicators, hopefully someone can build that for interventional cardiology, that all these risks are going to pop out. You're going to, as soon as you enter your procedural report and you enter whether it was Impella assisted, complex PCI, or it was like a straightforward lesion that you fixed in, a mid LAD, and it was a very good, IVUS, which I know IVUS and OCT is not widely used, but that's where Europe is going, right? Like everyone is IVUS, and, everyone is using imaging to figure out how the stent position is. So I think once, I personally feel like in 10, 20 years, we are going to be using much more personalization, and perhaps then we are going to be feeling more comfortable with, monotherapy early on. But yeah, till then, I absolutely agree with you. My gut as a cardiologist always wants to keep the patients on DAVs. So we'll see how the future enrolls.
Yeah, no. So you mentioned a few great points. So definitely personalization is the way forward. Using objective scores, so DAPT. Sometimes I use precise DAPT. Assess their bleeding risk in patients with, like you mentioned, multivessel disease, multiple stents, complex disease, calcified disease. I would tend to go longer with dual antiplatelet therapy. In patients with, type A lesions, single vessel disease, good stenting, image guidance, and if all of that's done properly, then you can argue stopping it in maybe 1 month. I still actually go all the way up to 3 months, even though I know there's 1 month's data. So I think I find myself a bit sheepish, stopping it prematurely, like more like if it's less than 3 months, I remain skeptical, and maybe I need to be a little more brave to change my practice. So I again agree with you. Personalization is the way forward, which brings us to our final trial, which is AQUATIC, and that again answers an important question on what I call as dual antithrombotic therapy. So these are patients who have an indication for being on an anticoagulant for, either venous thromboembolism or for stroke, mitigation of stroke risk in atrial fibrillation, and for whatever reason are also on aspirin.
Yeah, and I think, so AQUATIC, another aspirin, trial, I think very well done. Again, stands for assessment of quitting versus using aspirin and stable coronary artery disease after stenting with indication of long-term oral anticoagulation. So these were the patients who were more than 6 months out of PCI, again published in NEJM, double-blind, placebo-controlled trial, and they saw if aspirin was good or not. And the background of this comes from multiple other trials like AFIRE, PREDO-AF, EPIC-CAD. All of them have shown that if you use antiplatelet therapy on top of oral anticoagulants or DOACs, direct anticoagulants, it increases the bleeding risk without providing any clear benefit in the ischemic events. But most of these trials that are done, the argument is that they're all from Asian countries, and perhaps the risk of thrombotic versus bleeding risk is different, from the Western population. So these investigators, they enrolled around 2,000 patients, but the trial was stopped. Why it was stopped is because actually there was excess mortality in the aspirin plus DOAC arm. So even though the goal was 2,000, they only analyzed or included 872 patients that were randomized to DOAC plus aspirin 100 once a day versus DOAC only plus placebo. Around 72% of the patients had MI, so even chronic CAD, but with a background of, myocardial infarction. It was not all stable heart, stable CAD. Reason for the anticoagulation, 89% all AFib, and that's the patient population that we deal with, right? Mechanical heart valve in 1%, and most commonly used DOAC was apixaban, I think in around 90% of the patients. And the primary outcome was composite of cardiovascular death, myocardial infarction, stroke, embolism, coronary revascularization, and acute limb ischemia. And the follow-up was around 2 years. So as I said, of a higher rate of cardiovascular death in the aspirin arm, around 7% versus 4%. But there was no significant difference in the individual outcome or the stent thrombosis. All-cause death was also high when the aspirin was, added. And the key safety outcome was the major bleeding, and which of course happened in presence of aspirin, around 10% patients in the aspirin plus DOAC arm versus 3% in the DOAC alone. So, again, kind of similar, theme, but once you have these patients treated with, they have stent and you are 6 months out, can you stop aspirin safely? And it seems like the answer here is yes, you can keep them just on DOAC if they have AFib as well as the stenting. Again, if we look at the chronic CAD, guidelines, we tend to go after, like DAPT for 1 month, and then you want to keep 1 year of, one antiplatelet agent, and one antiplatelet agent can be aspirin and Plavix. I think most of the times, at least in United States, if we look at the guidelines, they say clopidogrel plus DOAC. But, this again makes you think whether we should be stopping that at 6 months rather than 1 year. And again, who do we stop it on? How are we going to feel about it? That's the, that when does the practice change is the question to be answered with all of these therapies, where we are really trying to back off on the, drugs that we had previously pushed forward to.
Yeah, so Purvi, I'll be honest with you. So I was very happy to see AQUATIC being published in New England, and I'll tell you why. There has been, or I should say, there have been accruing data, multiple observational papers, which have tried to answer this question of whether or not we should continue aspirin in patients who have other indications for being on a DOAC and have chronic coronary syndrome. And when COMPASS was published, and I know I'm sort of extrapolating, one trial's data to another set of patients. However, there were data published in chronic coronary syndromes and patients who were requiring anticoagulation, and there was a signal toward increased bleeding with a combination of aspirin plus an anticoagulant. And so I want to say maybe about definitely in the last 1 year, but I want to stretch out and say maybe last 2 years, I just started stopping aspirin in these patients and saying, you just be on your apixaban, or just be on a rivaroxaban, or just be on your dabigatran. You don't really need aspirin. And so when this was published, I was like, okay, it makes sense. It brought a smile to my face, because I was like, okay, it totally makes sense. Yeah, I mean, we're sort of, as we were discussing offline, this is like a moratorium on beta blockers and aspirin, sort of the cornerstone therapies in cardiology, and here we are in 2025 questioning their use and their existence.
Yeah, and it's fun how the future Parallax episode will unfold, and where are we going to see, the real world, kind of catch up to all of this. And no, it's been an exciting time to be in cardiology, so much advance and so much, credit to be given to those investigators who keeps us on our toes and, really challenge the status quo, and everything for the benefit of our patients who are, anywhere in the world, who are in abundance to be found. So I think it's good. It's good to be in cardiology. It's good to practice as a cardiologist in 2025, I would say. Right?
Yeah, no, it's a fulfilling field. I always tell people it's the most evidence-based field. There is not a question that you cannot find an answer to based on randomized clinical trial evidence for the most part, right? So I think that is the great part. I think the sort of a I don't really call it a tough part. I think it's just a fulfilling part. Also, is that you keep chasing the evidence as you keep garnering and building more evidence, and so it's always very progressive. It's always on the cutting edge. It's always very at the forefront of innovation and newer therapies and, questioning older therapies. So I think, no, I think it's keeps you and keeps you engaged, and it always keeps you involved, even as a practicing clinician, even if you're not a researcher. So it's just it's a fulfilling it's cardiology life is a fulfilling life, is what I would say. So if I were to do it over again, I would do it all over again. Uh, all right, very good. Well, so this has been fascinating. Again, thank you for another excellent episode. This should air maybe in the next couple of weeks. So um, uh, to the listenership, thanks for listening. Thanks for tuning in every other Monday. Do share your feedback with us. We take it seriously. If you have any questions for Dr. Parwani, do send them to us. You can send them to her directly. If we get them, we'll forward those questions to her. Purvi, any closing remarks before we end the show?
No, just was gonna say that it's always fantastic to do this episode. So thank you for again, bringing me back. And as I said, never a dull moment inside or outside the hospital. So keep living.
Awesome. Thank you. All right. We will see you other Monday. Thanks for tuning in.
We hope you enjoyed today's podcast produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.